Generalized Anxiety Disorder, or GAD, is a persistent and excessive anxiety and worry about various domains that the individual finds difficult to control. These domains may range from work and school performance, health and finances, misfortune of children, household chores, and punctuality. During the course of GAD, the focus of worry may shift from one concern to another. Before we explore the diagnostic criteria for GAD, let's take a look at a case example. Jo is a highly qualified and much respected primary school teacher. The kids love her and her colleagues respect her skills. What people do not see is that she is constantly anxious and spends hours preparing for her class, constantly ruminating about whether she is doing a good enough job. Her need to avoid any negative feedback means that her family gets frustrated with her as she does not spend as much time with them, which feeds into Mary's guilt and anxiety about failing. She worries about letting people down and losing her job, and as much as she tries to stop the worry, it feels uncontrollable. She becomes agitated if things change and is constantly wondering when the next catastrophe will strike. She is restless and on edge and is not sleeping well. In this case example, Jo portrays a number of symptoms associated with GAD. To be diagnosed with GAD, the DSM-5 diagnostic criteria are as follows. An extensive anxiety and worry occurring more days than not for at least 6 months about a number of events or activities. The individual finds it difficult to control the worry. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some of these symptoms having been present for more days than not for the past 6 months. Symptoms include restlessness, feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, and sleep disturbance. It is also important to note that children only need one of these symptoms to be diagnosed with GAD. Other criteria include the anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The disturbance is not attributable to the physiological effects of a substance or another medical condition, nor is it better explained by another mental disorder. A number of studies have explored temperamental, environmental, and genetic physiological factors associated with GAD. Temperamental factors such as behavioral inhibition, harm avoidance, and negative affectivity have been linked with GAD. Many individuals with GAD report that they have felt anxious and nervous all of their lives. Symptoms of excessive worry and anxiety that occur early in life may be manifested as an anxious temperament. Environmental factors such as childhood adversities and parental overprotection have also been linked to GAD. However, it is unclear which environmental factors have been identified as specific or sufficient enough for a GAD diagnosis. The clinical expression of GAD is relatively consistent across the lifespan. The primary difference across age groups with GAD is in the content of the individual's worry, which tends to be age appropriate. For example, children and adolescents with GAD tend to worry more about academic competencies, boarding performance, and the occurrence of catastrophic events. Older adults report greater concern about the well-being of their family members or their own physical health. For the elderly, excessive worrying may be related to the advent of chronic physical disease and individual safety. Walitsky, Taylor, and colleagues, 2010, suggest that young adults experience greater severity of symptoms than do older adults. A number of these studies have also noted that one-third of the risk of experiencing GAD is genetic, with these factors overlapping with the risk of neuroticism and are shared with other anxiety and mood disorders. A number of assessment tools can be used to help assess GAD symptoms in individuals. These include the Anxiety Disorders Interview Schedule, the Generalized Anxiety Disorders Questionnaire, the Generalized Anxiety Disorders 7, Penn State Worry Questionnaire, and the Hamilton Anxiety Rating Scale. The Anxiety Disorders Interview Schedule is a structured interview that helps therapists develop a comprehensive understanding of their client's anxiety and explore specific diagnoses for their anxiety disorder. The Generalized Anxiety Disorder Questionnaire is a 9-item self-report measure designed to screen for the presence of GAD. It assesses the full diagnostic criteria by looking at the presence, the frequency, and controllability of excessive worry, the number of endorsed worry themes and physical symptoms, and the interference and distress caused by these. The Generalized Anxiety Disorder 7 is a 7-item anxiety measure where items are scored from 0 to 3. The whole scale score can range from 0 to 21, with cutoff scores for mild, moderate, and severe anxiety symptoms being 5, 10, and 15 respectively. Increasing scores on this scale were strongly associated with multiple domains of functional impairment. The Penn State Worry Questionnaire is a 16-item self-report questionnaire on a 5-point Likert scale designed to measure an individual's tendency to worry excessively without reference to the specific content of their worries. Higher scores indicate increased levels of worry. The Hamilton Anxiety Rating Scale is a clinician-rated instrument that assesses both somatic and psychological symptoms, not specifically designed to evaluate the severity of GAD symptoms. It comprises of 14 items, each defined by a series of symptoms, and measures both psychic anxiety and somatic anxiety. Each item is scored on a scale of 0 to 4, with 4 being severe and with a total score range of 0 to 56, with scores below 17 indicating mild severity and scores equal or over 30 indicating severe. A number of evidence-based psychological interventions have been effective in treating GAD, with cognitive behavioral therapy being the most studied and most effective approach for reducing anxiety. CBT is a multimodal intervention for GAD that includes several components that we will discuss in more detail later on. CBT typically involves 10 to 15 60-minute sessions for GAD, but can include additional sessions depending on the patient's level of severity, the presence of comorbidity, patient resistance to the treatment approach, therapist competence, and a number of components incorporated into CBT. CBT treatment sessions are always accompanied by homework assignments, usually daily, to be conducted between sessions. Thus, therapy time for the patient is more extensive than the time spent in session with therapists. Symptoms of GAD that CBT addresses are cognitive symptoms of excessive and uncontrollable worry about a number of different life domains, physical symptoms of muscle tension, vigilance, restlessness, inability to relax, poor sleep, and poor concentration, and behavioral symptoms of excessive preparation, procrastination, poor decision-making, and avoidance. The central focus on CBT for GAD is teaching patients a set of cognitive and somatic coping skills to effectively manage their anxiety as they are repeatedly exposed to anxiety-provoking images and activities. Treatment begins with education on correcting their misconceptions regarding anxiety, worry, and associated symptoms, causative factors of pathological worry and anxiety, a model of factors that perpetuate GAD, and the treatment plan and rationale. Much of this information is integrated in how a pathological cycle of worry and anxiety develops and can be maintained in patients' lives. Self-monitoring is introduced in the first treatment session and continues throughout the entire treatment. Patients are taught to become personal observers of their own anxiety and worry. Relaxation training can be particularly meaningful for GAD patients as they often experience elevated muscle tension and reduced flexibility of autonomic functioning. In training, clients learn techniques of relaxation to control excessive levels of tension. Clients learn to implement skills of cognitive restructuring to replace catastrophic appraisals with more evidence-based and coping-oriented appraisals. Patients are also encouraged to apply the cognitive and relaxation skills during exposures to images of feared negative events and to anxiety-provoking situations, as they prevent themselves from engaging in overt and subtle avoidance behaviors. In imagery exposure, patients generate hierarchies of fear images related to 2 or 3 main areas of worry and are led to these images through systematic exposure, generally once anxiety levels have reduced to a mild level. Exposure to anxiety-provoking situations involve repeated exposures to situations that are avoided or engaged in with excessive preparation or checking. Patients rehearse cognitive restructuring and relaxation coping skills during each session. A final step in CBT is relapse prevention, in which patients are informed that recurrences of worry, anxiety, or avoidance behavior are likely to occur in the future. Clients are encouraged to view such recurrences as lapses rather than failure, and to reapply their coping skills and reinstitute their practice of exposure to images of negative outcomes and anxiety-provoking situations. Other empirically based psychological treatments include emotional regulation therapy and mindfulness, acceptance, and commitment therapy. Although nearly all clinical trials of psychotherapy are effective in GAD focus on CBT, other psychotherapies have received limited study in patients with the disorder. Due to time restrictions, they will not be explored in detail today. Pharmacological interventions such as the use of selective serotonin reuptake inhibitors have also been effective for treating GAD. SSRIs are antidepressants that can relieve anxiety symptoms and help reduce the symptoms of depression that often accompany anxiety disorders. It usually takes 2 to 6 weeks for SSRIs to start reducing the anxiety, and they are only effective in some people, though so may be necessary to try various medications. Escitalopram and paroxetine are two SSRIs for people with GAD that are well studied and have been approved in Germany. If an SSRI is effective, it is recommended to take the medication for another 6 to 12 months and then gradually reduce the dose over time. Research suggests that this lowers the risk of anxiety returning. It's sometimes difficult to keep taking the medication regularly. One reason might be the side effects, but people also tend to stop taking the medication when they start feeling better. Possible side effects of SSRIs include nausea, insomnia, and sexual dysfunction, but most people don't have any side effects. Assessment scales such as the GAD-7, the PSWQ, and the HAMA may be used to measure treatment outcomes in patients with GAD. These scales were discussed earlier for assessing patients with GAD. Earlier it was mentioned that increasing scores on the GAD-7 scale were strongly associated with multiple domains of functional impairment. Readministering this questionnaire post-treatment may allow us to see a reduction in scores, suggesting an improvement in anxiety symptoms and less functional impairment in a number of areas. Additionally, the PSWQ may be administered post-treatment to explore whether there is a decrease in worrying tendencies in clients. Scales such as the HAMA is widely used as an outcome measure in clinical trials, where a decrease in scores may suggest an improvement in somatic and psychic anxiety symptoms. However, the HAMA has been criticized for its occasional poor ability to discriminate between anxiolytical and antidepressant effects, as well as somatic anxiety versus somatic side